Now we have Dr. Yen Ying Lim, who is speaking to us next. And again, Yen has worked on a number of projects over the years, including on the ABLE study. And she is currently an HMRC Career Development Fellow here at the Florey. And she's also the recipient of multiple grants now. She's been superstar successful the last couple of years. She's now head of the Cognitive Health and Ageing Outcomes study or lab, and the lead investigator for the Healthy Brain Project, which is a fantastic project that's really, it's been her work and her initiative. As a cognitive psychologist, her research interests are in the effects of genetic, biological and lifestyle factors on cognitive health. She's interested in all of the potential impacts and clinical disease progression in clinical Alzheimer's disease. Thanks, Yen.
Thank you very much, and thank you so much for inviting me to be a part of this symposium. As Amy has mentioned, I typically operate within the world of Alzheimer's disease, so coming into the vascular field is a little bit daunting, but I have some results to sort of share and talk you through. Thank you for accommodating my height. I first want to give you a little bit of context to the Healthy Brain Project. We started this as a result of a couple of studies that I ran, and other people have as well conducted, in ADNI and ABLE, looking at the rates of amyloid accumulation across cognitively normal adults. So this analysis was done with Beth Momino at Stanford University using ADNI data, and what we found was that in amyloid negative people, so these are people who are cognitively normal, amyloid negative, usually we would just say you're fine, don't worry about anything, and we'd often ignore them. But in amyloid negative people, we see evidence of amyloid accumulation in people who are ApoE4 carriers. So people who carry the risk gene for Alzheimer's disease, despite the fact that they're amyloid negative, show this increase in amyloid accumulation. And this amyloid accumulation is also related to cognitive decline. So the faster the rate of accumulation, the faster your cognitive decline in amyloid negative people. So this suggests that this trajectory of Alzheimer's disease begins much, much earlier. These guys are about 75 years old, but it suggests that it begins a lot earlier, possibly in midlife. And so it is in this context that we established the Healthy Brain Project. We know that ApoE4 carriers are important. Understanding ApoE4 carriers are important. So if we're going to recruit a whole bunch of people really quickly from the population, we would target E4 carriers. And to understand the genesis of Alzheimer's disease right at the very, very beginning, we need to go into the midlife, into middle-aged adults, people age 40 to 60, 40 to 70 years old, target the ones who have a family history of dementia so that we increase the prevalence of ApoE4 carriage in our sample and study them over a really long period of time. Of course, the other thing to consider too is that a lot of studies in Alzheimer's disease at the moment are conducted in older adults, right? And they also exclude, almost exclusively, the influence of cardiovascular, cerebrovascular risk factors. And we all know that cerebrovascular risk factors and cardiovascular risk factors occur a lot in midlife. So as amyloid is likely accumulating, cardiovascular risk factors are also starting to have an impact in this middle age time. But the fact that they're middle-aged, they're young, they're healthy, they're working, going about their own lives, the effects that we're going to see in these people are going to be small. And subtle. So the way to get around that is that we will need a lot of people. And how do we recruit a lot of people? We're recruiting them online. So the Healthy Brain Project is an online study. People do everything online. They go onto the website, they do online consent. We do specifically try and recruit people with a family history, first or second degree family history of dementia. But as you know, it's an online study, so if people say they do, but they don't actually do, that's one of the limitations, one of the considerations when we interpret the results. This is our process. They go online, do online consent. They are enrolled into the study. They confirm that they don't have a neurological disorder. They don't have they have a family history. They all these sorts of things. And then once they're enrolled, they complete a series of modules online, and they can go through it at their own pace. There is no requirement for them to do everything in one sitting. It's designed to be quite flexible for them so that they, they're middle-aged, they're 40, 70, they're working, they have kids, they have everything else going on. We want them to be able to, come on, do a bit, go home, do a little bit more the next day or next week. We do send them reminder emails if they haven't completed them within 2 months. And then once everything is completed, we send out a saliva sampling kit and to get a sample of the saliva to do genetic testing. This is the modules that we have. We try and be as comprehensive as possible. We ask them everything and anything under the sun. And I haven't listed the exact tests that we have for them, but if you're interested in the details, you can come speak to me afterwards and I can share those with you. Because it is a big study, we've taken the option of creating data freezers. So we have, in August 2018, we created our first data freeze for analysis. We have a lot more people now. We have, I think, over 6,000 participants now. So this needs to be updated. But this is a sort of sample snapshot of what our study looks like. We have 35% E4 carriers, which is really nice, a little bit higher than the population prevalence, but that's what we would expect. We have representation across all of Australia's states and territories. Obviously, the most common one, the most prevalent one is from Victoria. We have a lot of women. We need the men to step up and lean in and, participate more, but I think that's a common problem of a lot of studies, especially online cohort studies like the Healthy Brain Project. But it's really nice to see that the demographic variables in terms of their income and their education, we're not looking at a highly educated population. We're looking at something pretty average comparable to the Australian population. So about high school education, about a quarter of them are non-Caucasian, about a quarter of them come from rural Victoria, rural Australia, which is nice. We asked them about their medical history. So this is a summary of their current and past medical history. So a lot of them have obviously the common vascular diseases that we would see, and also the medications. So about 20% of them, 20% to 25% of them would take antihypertensive, statins, etc. So how do we measure cardiovascular risk remotely? All of it has to be self-report. And so we ask them about the self-report history of hypertension, self-report history of hypercholesterolemia, self-report history of diabetes. It's not perfect. And one of the questions about this whole online remote assessment platform is, well, is it even possible? And is this data valid? Can we reliably assess people through this remote assessment platform? So by doing that, we thought we'd look at some of the more commonly known associations between medical history and cognition, and use that as a means of validating the platform that we're using. So by using this, we've got 5 different variables. We've classified cardiovascular risk as somebody having 2 or more of these risk factors. That categorization can be a little bit arbitrary, I know, but that's sort of what we went with for now. And what we do see is that high cardiovascular risk is associated with worse memory performance. So this is, how do I get the, never mind. The vertical axis is the magnitude of difference, so that's an effect size. You can interpret it as a standard deviation. As you can see, it's small. Right? These are middle-aged, average age of 55, they're young, they're healthy. Any effects that we're going to see is going to be small. But despite that, we do see a significant difference between those who have high cardiovascular risk and low cardiovascular risk on the measure of learning and memory. And these results are adjusted for age, sex, and education, and all those sorts of things. When we load all of the factors into the model to look at the independent effects of each, we see that obviously age is a significant predictor of cognition, but also obesity and smoking is a significant predictor of cognition as well. I wouldn't read too much into, why is it obesity and smoking and not hypertension and all that sort of stuff, because as I said, there's going to be quite a bit of noise around, whether or not they report themselves as having a self-report history of hypertension and hypercholesterolemia. It's not like we're collecting blood from them and measuring it directly. We do have a cohort of people who will come in, about 400 of them who will come in, and we'll do biomarkers on them and imaging and all that sort of stuff, and we'll be able to characterize those people a lot better. But this is just sort of a really rough, ready kind of assessment of a person's cardiovascular health using self-report, using an online platform, and we're still seeing these relationships, which makes me really, feel good about the platform. So vascular risk factors don't occur in isolation, as you know. This is, there are all of these other risk factors that happen at the same time. So there's like poor mood, there's poor sleep, there's low cognitive reserve, all that sort of stuff. So one of the next steps for us would be to try and incorporate some of this into a structural equation model of some sorts, or even try and develop almost a lifestyle risk score to try and predict cognitive decline or cognitive change in the future. So there's a couple of considerations. The question that we set out to answer was, is it feasible to collect data from an online platform? Yes. How valid, how reliable is that data? We're still working on that. Some of our initial results do suggest that, it is working the way that we want it to work. We are getting the results that we see that are similar to that seen in in-clinic cohorts. There is, we do have this reliance on self-report, and as we all know, the limitations around that, but we need to balance that against, large-scale sampling, against generalizability and participant convenience. So it is a community-based sample, but it's not an epidemiological sample, right? Because we've definitely gone out and set out to get people who have a family history of dementia. But despite all this, it does suggest that the data is valid and real. It's behaving similarly to other in-clinic cohorts. And even though it's a little bit, it's a lot female heavy, it is largely representative of the Australian population as well. So I think in the future we'll have a lot more data to present and hope to participate in this discussion of the contribution of amyloid or Alzheimer's related pathology and vascular related pathology and their independent and synergistic contributions to cognitive decline and cognitive function. So that's it. Thank you very much. I'd like to thank all my participants, all 6,000 plus of them, and my co-PIs, Rachel, Nawaf, Matt, my mentors, especially Paul Maraf, who I'm not sure is here, and obviously my amazing team of RAs who worked tirelessly on this project. Thank you very much.
I think this is, exactly what the field needs. I mean, whilst it is, as Ian said, a community-based study, not an epidemiological study per se, I think that to be able to get these numbers and self-report in general is pretty good, except for alcohol consumption and sexual activity. Apparently, that's it. People, cigarette smokers are honest about their smoking, which is good to know. So that's.